Yes, so yeah, not only am I the director of the Open Foundation, I'm also a researcher, and that's what I want to talk to you about today. Um, Context matters. Why clinical psychedelic research needs patient perspectives. And I'll tell you a little bit about why I think that's crucial to know. And the way I'm going to do that is by way of discussing the two currently most studied drugs for the treatment of depression, the most studied psychedelic drugs, psilocybin and ketamine. And before I go into detail about what I've studied, I'll tell you a little bit about the context of these two drugs. So, starting with what we know, and starting with ketamine. And the evidence base for the use of ketamine in the treatment of depression is substantial. I've just handpicked a number of systematic reviews and meta-analyses reviewing the efficacy and the safety of ketamine for the treatment of depression. There's meta-analyses of meta-analyses. There's a Cochrane review, which is probably the highest level of scientific evidence that you can get. So we know quite well how well ketamine works for the treatment of depression. And it's nicely summarized in this forest plot. This doesn't contain all the most recent studies, but it gives you a good indication. I don't think much has changed since the publication of this one. And what we know is that ketamine has the strongest effect on depressive symptoms in the first 24 hours after administration. So that's, apologies, that's this forest plot. So the effect sizes reduce a little bit at 3 and 4 days here, and in most cases, the antidepressant effect has worn off by the first week. So this we know. We also know quite a bit about biological mechanisms of ketamine. I won't go into detail. My background is in philosophy. I do qualitative research. I'm not a neurobiologist nor a pharmacologist. But we do know that ketamine induces synaptic plasticity, spinogenesis, neurogenesis. We know from animal models, as Julia has told us about before, using models such as the forced swim test, that ketamine is active for the treatment of depression. However, there are many things that we don't know when it comes to ketamine. For instance, psychological mechanisms. We don't really understand well what the psychological mechanisms, if any, are of ketamine treatment for depression. And the way that this has been mostly studied is using looking at the most used questionnaires studying subjective effects, mostly looking at dissociation. And this is I'll dive into what dissociation means and what it doesn't mean a little bit, because it's a bit of a pet peeve of mine. And I'll do that by way of two relatively recent reviews that have looked at studies taking these psychometric questionnaires, studying psychoactive effects, and correlating them to therapeutic outcomes. And there's quite a few of them. This is a study by Miriam Grabsky. You probably won't be able to read this. If you zoom in a little bit, you'll see the measures on the left-hand side and the association on the other hand. And if you just glance over it, you can already tell that for most of the measures, there's no association. This is a study by David Mathai at Johns Hopkins. It did basically the same thing. No association found for the most part. Right? So measuring dissociation doesn't correlate with therapeutic outcomes for depression. And then if you look at it a little bit more carefully, of all the measures done, the CATS, which is the clinician-administered dissociative states scale, is the mostly used. The majority don't show any correlation with therapeutic outcomes, with a few exceptions that do correlate in some cases only for a subscale, the depersonalization subscale of the CATS, and in one case it actually correlates negatively with suicidal ideation. So the evidence using psychometric measurements isn't very strong. Then when we look at patient experiences, this is a review I did in 2020, looking at qualitative research, focusing on patient experiences. There was only a single study looking at patient experiences with ketamine. There's been quite a few since then, but at that time there was only a single one and only a mixed method study. So they used relatively little qualitative data. So at the same time, ketamine is administered, it's offered quite broadly, especially in North America. There are billboards out there promoting ketamine treatment. I saw a hilarious but also quite scary Instagram video by Field Trip. This was during the COVID pandemic, where people were allowed to get at-home prescription of ketamine because they weren't able to go to clinics. And you know, at-home freedom kit containing ketamine. The focus was on the organic tote bags with zippers, not so much on the ketamine, and even less on the optimal support setting for the use of ketamine. And what it looks like, this is also in the US. These are photos taken from the insides of ketamine clinics. I think the majority of the clinics don't look like this, actually. These are very high-end wellness-type spas where you pay thousands of dollars to get a ketamine infusion. I think the majority are actually much more bare bones. So this is already happening. Ketamine is used to treat a variety of mental disorders. And then if you look at what the experts say, this is a publication from a few years ago. This is the most that I could get from this on the importance of the context in ketamine treatment. Appropriate cardiorespiratory monitoring, safety assessments, monitoring patients until they're stable, reliable transportation at home, but nothing about the importance or the role of support during ketamine treatments, about preparing patients, about psychological effects, subjective effects of ketamine. So, like the common opinion is that ketamine is a biological antidepressant, and the psychological subjective effects, they don't matter that much. This is a quick summary of what we know and don't know. Then, when we go into psilocybin, what we know is there have been 7 studies. Over 500 patients have so far participated in clinical trials with psilocybin for the treatment of depression, using like a variety of different dosages, dosing regimens. The majority have actually used a single dose of psilocybin for the treatment of depression. A couple of studies have done double dosages. And the outcomes have been monitored for relatively little time. Pardon me. 3 weeks, sometimes 6 weeks, at the most 12 weeks. The Carhart-Harris study from 2018 did a long-term follow-up at 6 months, but that was an open-label study in a small group of patients. So they use different outcome measurements. They use different models. Some cases they use placebo. In some cases they compare it against wait lists. So there's no real coherence in this field either. And if you look at the effect sizes, the majority, apologize, they do a little bit better than placebo. It matters a lot where you compare it to. If you compare psilocybin against wait list, which is basically nothing, then you get a very strong effect. If you compare it against escitalopram, as in the famous Carhart-Harris study in the New England Journal of Medicine, you don't get quite as good results. And this is only on the short term, so we don't really know what happens on the long run. Other things that we don't know include the occurrence or the prevalence of adverse events. I know that Abigail spoke about this yesterday. But we also did a study where we looked at how adverse events are reported in the clinical trials with psychedelics in the current wave of psychedelic research. And there's a couple of things that stand out, and particularly if you look at the acute adverse events across different psychedelics, you see that one thing that recurs is anxiety. There's a psychological discomfort, maybe another term for it, but feeling different and feeling fearful and anxious is something that occurs actually quite a lot. But what does that mean? We don't quite know. I mean, anxiety is a very broad concept, and it could be that people have a very difficult time and have a harmful experience as a result, but it could also be that people need to go through a challenging experiences in order to learn something and to transform this into a positive outcome. And then looking specifically at more serious kinds of adverse events related to psilocybin treatments, a few have been reported. None of these have been reported as serious adverse events, which include post-traumatic flashback and a relapse into methamphetamine use in the study by Anderson in HIV survivors. One patient who got severely worse after participating in the first psilocybin for depression trial in 2016. There was one successful suicide after a patient participated in the placebo group in 2016. This was actually an end-of-life trial. May or may not have been related to the participation in the trial, but we didn't know. But because it was buried in the supplementary material, it's very hard to assess, to make an assessment. And this was based on the judgment of the investigators. And in the second most recent trial, the Big Compass trial, we could see that the incidence of adverse events increased with dosages. So people in the higher dose groups had higher rates of difficult experiences or adverse events than people in the low dose or in the placebo group. We do actually know a little bit about what patients experience. There's been a study interviewing all the patients in the Carhart-Harris trial in 2016 by Rosalind Watts. A beautiful study that showed that across the board, patients experienced increased connectedness and acceptance after participating in this trial. And it's a good example of the usefulness of qualitative research, because this led to new ideas, new hypotheses, new ideas about mechanisms on how psilocybin might work for the treatment of depression. At the same time, I always found it a little too neat, as if 20 patients with treatment-resistant depression all of a sudden felt more connected after participating in a trial. But as you can see, there have been a number of papers since then, and the concept of connectedness, as the authors themselves say, was already floating around in the community at that time. So there may have been like an unconscious way of introducing this concept into the interpretation of patients' experiences. I've been a little bit skeptical about the beauty of or the neatness of these results. So these are a couple of the things that we don't know. So just in summary, adverse events are relatively underreported in psychedelic trials, or at least we think so. The meaning or the interpretation of anxiety, what is optimal support, what is the role of psychotherapy, both in ketamine and psilocybin treatment, the optimal setting, the amount of sessions needed, subjective working mechanisms, the duration of integration or long-term follow-up, and how to prolong outcomes, which particularly in the case of ketamine is a big question, because most people need repeat administrations of ketamine in order to enhance their therapeutic efficacy. Maybe that's not needed. Maybe with more psychotherapeutic support that could be changed, but that's something that we currently don't know. And then what we don't know. That's something that we don't know, of course. But there's a way of addressing these questions, and that is what I do, qualitative research. Just a very brief explanation on how qualitative research methods relate to quantitative methods. Basically, qualitative research asks different kinds of questions. So instead of trying to measure or to quantify or to reduce measures by asking how often does something occur, how many people experience this, it's trying to get to the meaning or to the interpretation of what people experience by asking why or how or in what way. So it's more descriptive, it's more holistic, and interestingly, it's more geared towards hypothesis generation instead of hypothesis testing. So it's more open-ended, more exploratory than quantitative methods. So I'll tell you a little bit about what I have done so far using qualitative methods. I'm going to combine the results of two different studies that I've done. where I've interviewed patients who participated in a psilocybin trial and in an off-label ketamine treatment, all in the Netherlands. So I've interviewed 11 patients participating in psilocybin treatment, 17 in esketamine treatment. Esketamine is available as an off-label medication in the Netherlands. So that's the left-turning enantiomer of ketamine. In both cases, the groups were relatively comparable. In both cases, this was TRD, treatment-resistant depression. There is no consensus definition, and because in the off-label treatment, these were patients, basically anybody could be included, and these were patients who were severely treatment-resistant, who in a majority of cases had tried multiple psychotherapies, multiple medications, augmentation medication, antipsychotics, but also different treatments such as deep brain stimulation, ECT, TMS, transcranial magnetic stimulation. And in the psilocybin trial, the definition was a little bit more strict. So people had to have had an insufficient response to antidepressant medication, specifically between 2 to 4 different medications. So this is an overview of what the treatment regimen looked like. Ketamine was given twice weekly, starting at a low dose of oral ketamine, which is 0.5 milligrams per kilogram, and then slowly tapering up each week until a maximum of 3 milligrams per kilogram. And then I really thought about this, what is the best way to get people's, to come as close as possible to people's experiences during the ketamine treatment, and I decided to do a single interview right after the end of the initial 6 weeks ketamine treatment, because this was also the moment that the clinician and the patient decided together whether or not to continue treatment. And eventually patients were able to continue treatment if they had a good therapeutic effect and even could continue at home. It was a little bit different in the psilocybin study, and as you can see in the first graph on the top, there was no psychotherapeutic report. It was basically you get to the depression clinic, you get a little tiny cup of liquid, you take it, you lie down, and then at half an hour some nurse comes by, takes your blood pressure measurements, and that's it. In the psilocybin trial, in the first 3 weeks, people got 3 preparatory sessions of 60 to 90 minutes each, and then at week 3 they got a single dose of psilocybin. This was blind at the time, by the way. So this was blind to me also. The deblinding was done only after everybody had been included. And I'm talking about the COMPASS trial, by the way. So these were participants at 2 different sites in the Netherlands who participated in the COMPASS trial for depression. So this was a little challenge for me because I did not know whether patients had had a placebo dose, a medium dose, or a high dose. It was nicely distributed, I found out in the end after it was deblinded. But because of the study protocol, I could only interview patients at least 3 months after their participation in the trial, and in some cases this was 10 months after their psilocybin session. So there's a problem with recall of the experience, but also there may have been layers of interpretation of their experiences in that time. And in terms of context, this is what the depression ward looks like in Groningen, where which was one side. This is where people receive their ketamine. There's a third chair there, and in some cases there were 3 people receiving ketamine at the same time, which I can tell you is not ideal. This is a depression clinic in The Hague, one of the other sites, which is an inpatient clinic, so patients stayed there for the duration of their treatment and receive ketamine in their own little room in the depression clinic. The psilocybin room was in the same psychiatric department at the University Medical Center Hospital, which was dressed up a little bit more nicely, but it's a very old building. It's not very beautiful, but they tried their best to make it a little bit more aesthetically pleasing. So what I will do next is I'll take you through some of the results. I won't take you through a lot of the phenomenology, maybe a little bit if I have time, but I'll share some of the insights that patients have given me, particularly related to the context and the setting of the treatment. So combining results from 3 different studies. And I'll read you through the citations, and just to make you aware, the citations are illustrative of some of the themes that we found during our analysis. We use an interpretative phenomenological analysis, or IPA, which really looks at how patients interpret their own experiences, how they make meaning of their own experiences, and we analyze each case individually before looking at broader themes across these different transcripts. So I'm combining some of the results from the psilocybin and the ketamine interviews. So on the role of support, this was a patient who received a placebo dose in the psilocybin group. She said everything was set up so nicely. I'm demanding, really very perfectionistic, but I found little that needed to be done differently. It was really perfect in my experience. Being cared for by a professional for a whole day, putting a blanket on me, turning on the music. I felt like a child there, and when I left, I felt like I'd been with a group of friends. So this person, despite having had no experience, and she was not a responder in this treatment either, she had felt that she'd been cared for very well. And this is the experience of most of the people in the psilocybin treatment. It was very different for the people participating in ketamine. As I said, people arrived there, they got a little bit of explanation about what ketamine is, then they got a cup of ketamine to drink, and then they were put in a room by themselves, and then wait until the effects had worn off before they could go home. And this person said, the nurses, they don't get it. They're nice, they take care of you, they provide security and so on, and they do that very well, but they have no idea what you're going through, unless they've used ketamine themselves, which they haven't. And in some cases, people were allowed to bring somebody there, a family member or a friend or a partner, and that really helped them in letting go and accepting the experiences and going with the waves of the experience. They said the few times I did manage to surf the waves were the times my husband was there. Having somebody I trust completely sit next to me ensured I could also think of it a bit more like an adventure instead of just resisting it. And this was a patient who had a very difficult time. This was probably the only session that wasn't very, very negative and very difficult for her. So that teaches us something about the role of presence, of support, and also the potential role that others, informal support givers, can play. The physical setting, some of the sub-themes that came out of this were the importance of privacy. You can probably imagine this if you're sitting together with 3 people, your senses are heightened because of the effects of ketamine, and it becomes a very intimate atmosphere. And one person, this first participant, said that she had to take medication to lower blood pressure, which meant she had to start the session 20 to 30 minutes later. So the peaks of the experiences weren't synchronized. And she told me about an experience which she said was very difficult because I'm easily distracted and sensitive to sound. And one time, at the peak of her experience, a partner just turned on the radio. And even my friend was like, God, should I say something about this? So, and my colleagues were rough. They were largely unaware of this. They had no idea that patients found this difficult. So after I'd done a few interviews, I shared this with my colleagues, who then decided to, okay, maybe find a different space, maybe make sure that patients don't do the sessions at the same time. And really, the clinical staff at the hospital is nice, and they are professional, and they're effective, and they're caring, but treating this as a regular medication, I mean, it presents all sorts of challenges, and people are reluctant to share this, unless you ask them very explicitly. Some other person at the depression clinic in The Hague told me, you just hear it when somebody comes in, even when you're in the middle of a session. And this happened, right? At the peak of the effects, even when people take it orally at 30 minutes, most people are at the most intense moment of their experience, and then somebody comes in and does blood pressure measurements, and in some cases they have to take questionnaires, which completely interrupts their experience. And this was in the inpatient clinic. Somebody said, I told the nurses no knocking when you come in, and they had to teach them to put on a sign for the cleaner, because in the middle of a session at some point, just the cleaner came in and started cleaning the room because they were unaware that she was having a ketamine treatment. So goodbye trip. And the role of music varied quite a bit. There was no music at all during the ketamine treatment. The psilocybin treatment had a standardized playlist. For some people this was very cliche, for some people it was meaningful and supportive. But the people who liked it said it was very important. The music, they said, sounded extremely beautiful. It made the experience more intense, and another song would come on and I would just go again whoosh into the experience. So it very much guided the process. And I think this is really an underused instrument, especially in ketamine treatment, because it not only enhances the privacy because you're more absorbed in your own experience, but it can be used to guide the process and to give people a sense of support as well. Trust was a very big issue in both the ketamine and the psilocybin treatments. Trust related to the therapist, to like interpersonal trust, to the therapeutic intervention itself, but also in the substance. And a big part of this was that many people, these were all people who were treatment-resistant depression, and many people had tried very many different interventions, therapies. They'd met a lot of different therapists, and they were kind of sick of it, which is understandable, I think. And this person said it beautifully. She said, I must say that honestly, I'm a bit tired of therapy. I know it all, and you get all these questions, and I think, oh God, here we go again. I'm a little bit therapied out. So that's it. It's important to consider that for many people, they have to, even if they want to get better and they want to try anything to get better, they still have to go over a hurdle to really go and enter into a trusting relationship with people. And I mean, there's a lack of trust or some healthy skepticism or mistrust of the substance itself as well. So this person said, this is a fascinating case, by the way. He said, I am very skeptical. If it sounds too good to be true, it probably is. And that's what it sounded like to me. This is psilocybin, by the way. I have zero experience with drugs. I don't know what it's going to do to me. Will I get addicted to it? Obviously, the researchers, they want me to take the drug, but they don't have to take it. It's in their interest if I participate. So you can sense that there's a little bit of distrust in the researchers and the therapists as well. And this was a very fascinating case. I found out that he had indeed received 1 milligram, and he told me, it was a very short interview. He told me I took the medication, I laid down, and then 6 hours later I woke up, and that was it. And then I went home. And then by the time the study was de-blinded, this was over a year later, he was completely free of depression. Like the moment he woke up, his depression was gone, and that was it. And he got a placebo dose. I don't understand it, but it's fascinating. And of the people that I've interviewed, 3 of these people were responders at 3 months, and only one of those had received 25 milligrams. This was a person who had a classical, transformative psychedelic experience, and 2 of the others had 1 milligram, like supposedly a placebo dose, or a microdose, who knows, a single microdose. And coming back to trust, people also said contact with the nurses remained very superficial, very brief. This again is in ketamine treatment. I know they're busy and I know they cannot hold my hand for 3 hours, but that's what they actually wanted, to have somebody there to hold their hands, to console them, to comfort them. But I found it very meager. I felt very left alone, which indeed they were. And I really missed the feeling of having somebody watching over me. And this is also a patient who had a very difficult time. And this was one of the most shocking interviews to me. She told me that at some point she had gotten very sick during the ketamine treatment. She had vomited, and she was lying there by herself. There was nobody there to clean her clothes. And she lived very close by to the hospital, but she left after the session was over. She left in her dirty, vomited over clothes. She left by herself to her home. There was nobody there to pick her up. There were no clean clothes, which to me was a little astonishing. And to my colleagues as well, to their credit, but still this was kind of the context in which this treatment took place. And I think this is very often the case when it comes to ketamine treatment. It's done as a very regular kind of treatment. Then another important process-related theme that came up, particularly in ketamine, but also in the psilocybin sessions, was a constant struggle for people between maintaining control over the experience and letting go of the experience. And this is something for people who've struggled with depression for most of their lives. This was, for many people, something that they inherently struggled a lot with, but it became reinforced, it became so much stronger during the ketamine sessions. And this patient, number 4, said, I found it very unpleasant to no longer be present in my body and to give up control. And it's something that I don't like anyway, but during the esketamine sessions, it happened very violently. And for many people, this was this triggered a kind of resistance, this created anxiety, and this created a feedback loop for subsequent sessions. So if they had a experience where they lost control, they started resisting it, they couldn't, they became anxious. This was the feeling that they were left with after the session, and that was the feeling that they had when they entered the subsequent session. So they entered with anxiety, being scared of losing control of the experience, which then obviously happened. So it became a very negative experience as a whole for them. Which is what the second patient said. I'd become very anxious, and yeah, then you lose control as a result of these frightening experiences. And for some people, I was just sharing this anecdote during lunch. This was also the case during the psilocybin treatment. This is a patient who'd gotten the higher dose of 25 milligrams, and she also said, I couldn't steer, I couldn't get in or out, I was just dragged along and I had no control. I was a character in a story and I just had to wait and see what was going to happen. And that was a frustrating thing. I just couldn't do anything. I thought, this isn't what we practiced. The idea was just to be aware of things and to let them go, and I just couldn't. And this is somebody who had a very, very difficult experience that remained with her for months after the session. They got a single session of psilocybin, and by the time I interviewed her, this feeling of being left alone or not being able to control their experiences was still there. So as I said, that led to a lot of anxiety for folks, and anxiety was a common theme throughout many of the experiences that patients told me about. So some people had overwhelming experiences that were actually positive to them. So this patient, the first one on ketamine, had an experience that I don't think was necessarily difficult or negative. She said, I'm just completely gone. I don't perceive the outside world either. I'm not able to move. I'm not here on Earth anymore. I'm floating somewhere in that infinite world thing that doesn't end, totally lost in infinity. And I remember this was a patient who was involved with meditation, who was already interested in altered states of consciousness, and was curious about these states, which was why he was able to kind of go with this experience and not resist it. But for the majority of the patients, most of whom who had no prior experience with psychedelic drugs, this was very difficult. As in the case of number 3, this patient said, sometimes I have this horror experience. I can't get out and I don't know how long it will last because time just doesn't exist. At first I think, shit, did I take too much? And then it goes wrong because it all goes too fast, and at a certain point I just can't think anymore. And I'm lost in darkness and I can't leave, and it takes forever. And it's just such an unpleasant experience. And you have to imagine this is in a context where people don't have any support. There's nobody there to reassure them, to reassure them that this is an experience that will end, that other people have had this experience. So this type of validation can be very important, but this was just not there for them. And in the case of psilocybin also, some people had very anxious experiences, an overwhelming feeling of deep, deep unhappiness. It was just there suddenly. Actually, it came out of myself, but it also came over me. Everything around me, everywhere I was, the whole environment was that unhappiness, that vulnerability, that loneliness, that feeling of being left behind. And I couldn't do anything about it either. I couldn't stop it. I couldn't save myself. I couldn't save anything. I was just drowning in it and hoping I would surface again. And this was a very moving interview. She also described in the same interview that she had experienced herself as a tiny, tiny bird who had just come out of the egg, and fallen out of the nest, and noticing that she was lying on the at the root of a tree and not being able to pick herself up, but there was already also nobody there to pick her up. And that was the essence of her experience, this experience of being by herself, of being lonely and not being picked up and nobody there to help her. She knew she wanted help, but she didn't know how. And that's the experience that she was left with, and that is the experience that remained with her after the treatment was over. So maybe I did not make this explicitly, but in the psilocybin trial, people had 2 integration sessions. If really needed, they could get a third, but in the context of the study protocol, there was a single integration session on the day after the psilocybin session, and a second one about a week later. And obviously for this person, that was not enough. And that relates to this theme, I think, which is especially, well, both in the case of ketamine and psilocybin, actually very important. Patients express a need for a more comprehensive treatment, a more integrated treatment process, which relates to integration or aftercare on the long run, the need for multiple sessions. In psilocybin, there was only a single session, and especially if your first session is 25 milligrams of psilocybin, and it's very overwhelming and anxious, that can be very difficult. So some patients spontaneously mentioned that it would have been a good idea to start with a lower dose so that they could get accustomed to the experience and then gradually build up over multiple sessions. And having access to continued support afterwards as well, which also, in the case of the psilocybin trial, by the time the trial ended, that was the end of it. There was no continued support, there was no connection to additional psychotherapy or to other therapists. If you had a clinician that you were in a relationship with, that was there, but it wasn't part of the protocol. And that can feel like a big gap after the treatment is over. And this first patient said, who had a positive experience but didn't have a great response in terms of depression outcomes. She said that I don't believe one trip will completely rid me of my depression. I'm sure it requires more than that. I don't think it's a miracle drug. I think it's a miraculous substance, and it might help people. But I also think that maybe it's a process and should do it a little bit more often, which I'm inclined to agree with. And this other person also on psilocybin said, I did expect a little bit more support, and I really did feel the need for it. There were 2 talks, and that was it. But I did feel like I needed more, and it just wasn't possible. And people were also asked in this trial, they weren't prohibited, but they were asked to refrain from starting new medications or new psychotherapeutic processes so that it wouldn't interfere with the long-term outcome measurement at 3 months. So they were asked to not start any new therapy, even when they really did need it. And I mean, that was hard for patients because they did have monthly questionnaires over the phone, which is kind of, you feel the need to talk to somebody about your experiences, and what you get is like an anonymous person, a different person each time, every week, asking the same questions and the same kinds of repetitive questionnaires, which was really, really tedious for patients. And I know that people realize it, and that it's important to do, but also from the perspective of patients, this is a very heavy burden. And this patient also said to me, it felt like, this is it, bye-bye, you're on your own. And I didn't have a therapist at that time, so I couldn't rely on that either. And in the case of ketamine, this resonates with me also, they said that nurses, they did listen after the ketamine session, or the ketamine had worn off, but more out of politeness than that they really had the time, because they had to get on with something else. And I can understand that, but I think that if you have the space to talk about it, the experience stays with you longer, because it does ebb away. And this ties into what Peter was saying before as well, about the importance of writing down your experiences, of processing it. And all experiences are fleeting, but the ketamine experiences are especially fleeting. The content of the experience disappears quite quickly, as akin to a dream. And for those people who did write it down, or who did talk to somebody about their experiences, it stayed with them for much longer. So before I end, just a little call back to my comment on dissociation. I'll share just a little bit about detachment during the ketamine sessions. And I prefer using detachment because I have a problem with the term dissociation, which is relevant in terms of anesthesia, but not necessarily insightful in terms of a therapeutic process for the treatment of depression. But people did describe becoming more detached during the ketamine sessions from their self, from their body, which is obviously what most people know about the effects of ketamine, but of reality, of this reality of their own emotions also. And people said it was like floating out of my body, going up and outside of my body, floating around freely without space, without time, lovely. And for some people, this in itself was a positive experience. Just being detached from their imminent, always present negative emotions, mind state. Just being detached from that for just 45 minutes to an hour was already a positive experience. Just remembering that it's possible to feel good as well. This other patient said, you just get sucked into one point, and there's no escaping that. You have no body, you're not a person, you're something else at that moment. It's strange, you don't know where you are. Are you just a cell, a particle, a part of something? Myself is just gone. These were really experiences outside of myself. And I mean, these are pretty spectacular experiences, especially for garden variety depressed persons. These are not psychonauts, these are not people who are necessarily interested in these experiences, but they were profound. But also for the most part, they didn't carry a lot of meaning to them. Except for this last person who said, I can't describe it very well, but you realize what you are. I am the universe, or I am being. You step outside of your little personhood. You get a kind of broader perspective on what you are, on what others are. And this feeling of unity was very strong. So the detachment actually led to a kind of feeling of connection. So I charted a little bit like the phenomenology of the ketamine experience. And in the intersection between these two domains, people describing mystical type experiences, effects on their perception, and experiences of detachment. I think it's in the middle of this Venn diagram where people describe experiences of stillness, of openness, of peace and calm, where there's a real therapeutic potential. And I envision it a little bit like this, like patients who are severely depressed, they have a very constricted mind space where anxieties and ruminations and negative thoughts or self-destructive thoughts are like, they appear very big. And what this detachment, this increased mind space, this experience of stillness, of space does during ketamine is it opens up this mind space. So whereas they're disconnected from themselves, from other people, from their external world, from their emotions, it increases their mind space, and relatively their anxieties and their negativity and the ruminations become smaller, and they become more in touch with all of these other domains. Yeah, so before I wrap up, I don't think I should go over all of the recommendations that came out of these qualitative studies. I'll leave this up for a little while. These are the recommendations that came out of the ketamine study, which I think is, if you look back at the expert opinion on ketamine treatment, there is zero mention of the importance of interpersonal support, of continued presence, just having somebody present by your side during ketamine sessions, of having a pleasant space, of preparing people about the effects. I didn't mention that, but some people were unaware that they might have effects even at the lower dose end of the dose range. So at 0.5 milligram, people say, you won't have any effects for the first 3 weeks, which people took to understand you won't have any subjective effects during the first 6 sessions. But what they meant was you won't have any effects on your depression until probably week 3. So people were completely unprepared for the experiences that they did have, as was the clinical staff. And then I think there may be a role to play for relatives, for partners, in terms of support during these sessions, and a lot of the other recommendations we talked about. And the same is true for the psilocybin. There's a lot of overlap here. One important one is, I think, developing trust with therapists is a big one because in the Compass trial protocol, people only met their co-therapists, so they were guided by 2 therapists during the final preparation session. So they did 3 preparation sessions, all 3 were with their main therapist, but only during the 3rd one did they meet the 2nd therapist. And then a week later, then you spend 8 hours together with 2 people who are watching you, which can be quite awkward and uncomfortable. And especially the 2nd person is somebody that they barely knew. And another thing also that I haven't really touched upon, which I think is very important, is expectation management. So managing expectations, managing potential disillusionment, disappointment, especially in the time that we live now, people have access to all kinds of information, and most reports about psychedelics are glowing and positive, including of ketamine, which raises people's expectations quite a bit, which means they also get more easily disappointed. Yes, if you have more questions, I'm happy to talk about it in a few minutes. I just want to leave you with this final thought by William Bruce Cameron, as best I can ascertain. Not everything that can be counted counts, and not everything that counts can be counted. And I would leave you with this slide. I would like to invite you all to the conference that we're putting up next year, ICPR 24, from the 6th to 8th of June in Haarlem, in the Netherlands. And I thank you very much for your attention.
Thank you, Joost, so much for this wonderful talk. All right, are there any questions over there? Do I have a volunteer who's helping me with this? Nope.
Thank you very much for your balanced talk. I have a question concerning esketamine. Differing from psilocybin, according to research I've read, with ketamine there's a big problem concerning physical addiction to the substance. In my practice, I do not prescribe ketamine or use it for treatments, but I have colleagues that do. And some colleagues have referred patients to me completely addicted to ketamine to get them off it after an attempt to treat addictions such as alcoholism. What do you think of the physically addictive properties of ketamine and the inconveniences that poses?
Yeah, so the question is about the physical dependence of ketamine and the potential of getting addicted. It's a potential concern. So we have a number of patients who are treated in this off-label protocol with oral ketamine, who have continued to take ketamine at home. It's another topic that I didn't include in my presentation, but that's something that we had no knowledge about, like how to inform people how to take ketamine at home, because they go to the pharmacy, they get ketamine for 2 weeks, for 3 weeks. And I did talk to a few people who said that they had this inclination when they felt really bad to take a higher dose of ketamine or to take it more often. But we haven't seen any addiction in our patient population. But it is a risk, and it's especially a risk when it's unsupervised administration. And I don't think it's just the risk of becoming addicted, but there's also the risk of urological disorders when used for a long period of time that I think my colleagues are even more concerned about.
Yes, we've also noticed, just to finish, problems with extreme stomach pain in patients that are using way too much ketamine.
Yes, exactly, yeah.
Cheers. You mentioned when you were talking about the psilocybin that there wasn't necessarily much difference in experience between people taking 1 milligram, 10, 25, or no quantifiable difference. People were experiencing a range of emotions at all dosages. I was wondering if there was anything similar with the ketamine treatment, because you said the concentration and the dosage increased throughout treatment. So did you notice anything where patients at the beginning were experiencing things that became stronger as the dosage increases, or was there anything that was quantifiable there?
Yeah, so just to correct you on the first bit, I hope I didn't say that the experiences were similar between 1 and 10 milligram and 25 milligrams, because people definitely had much more intense experiences at the higher dose range, and people had basically zero subjective effects during the 1 milligrams. And also, if you look at the parent study, the COMPASS study, the 25 milligrams was more effective in treating depression than the other two dosages. The problem, one thing, I can't quantify my results because I did a qualitative study, and the second problem is that I had chosen to interview people about their experiences as a whole after the whole treatment session. So I couldn't really relate individual experiences to individual dosage levels. I mean, and there was kind of a trade-off. The alternative would have been to interview people about their individual experiences, but that would have meant, you know, interviewing twice a week, which is also, you know, very burdensome for patients who have to continuously talk about their experiences. And the downside of that is that I cannot really relate individual dosages to individual experiences. But what I can say is that even at the lower range, that patients already had quite pronounced subjective experiences.
All right, final question.
Hey, sorry. Just we had a conversation yesterday about, you know, bottom-up regulation and what that may mean. And I was wondering here, because you are speaking about, well, the need to integrate more qualitative research in the way we go about these things. And since yesterday, what we've been hearing is about importance of integration, importance of setting, importance of appropriate support, importance of follow-up, and the reliability of support, which are things that can hardly be put into a clinical trial as we know them, all of those multiplicity of dimensions. So I'm wondering, while it's nice that you do the qualitative research and that other people do it, are there any instances of people coming together to reflect upon the things? You mentioned Rosalind Watt's research, you mentioned what you're doing, but to, in a way, push for these things to be also be put into the ways we know about knowledge validation and about evidentiary practices. Because you mentioned Cochrane reviews at first and how, well, in the Cochrane hierarchy scale of evidence, this will be the lowest. So, but what you're saying is this is equally important as the rest. So don't we also have to reflect upon the way we go about evidence and knowledge validation in these settings and to push for novel ways to go about these things more collectively or in a larger basis? Because there's a very fine line between techniques that push for reliable research and techniques that push for epistemic policing. So what is your take about that?
My take on all of that? So where to start? Yes, I think it's very important. I mean, it's not just nice to do qualitative research. And in our case, in the case of the interviews on ketamine treatment, I did. After doing only a few interviews and seeing that patients were really struggling, it was easy to go back to my colleagues and say, we need to change the way that we're treating these patients. And my colleagues listened to this, so we had a discussion. We involved the nurses and the clinical staff, and so we made some changes. We've developed a training protocol since then, so we're training future nurses who are working with ketamine to administer it in a better way. So it's, I think, a very concrete way that you can use qualitative research findings based on patient experiences and improving the treatment protocols. And I think this is a study that will come out very soon. At Imperial, they did a Delphi study on reporting on set and setting measures. So they did a Delphi study, meaning they got expert input from a lot of different experts, collecting all that information and refining that through a number of sessions to come with guidelines on how to report on setting variables in clinical trials. Because I agree, just reading very dry outcomes of clinical trials, so we administered MDMA twice, this was the initial CAP score, this was the final CAP score, doesn't really teach us anything about the process and the importance of the fact that it wasn't just administered in a certain way, but therapists were trained, the setting looked like this, and which are the important variables and how that can teach us about how to interpret the results of clinical trials, I think. But that's forthcoming. People are talking about that and they're thinking about that. And I'm absolutely unsure if I answered your question.
My question also is, I mean, you talk about a lot of managing of expectations, so I'm going to be unfair with this two-finger thing, which is, do you think that the research that's happening in psychedelics can also help change other paradigms about how support is provided, how outcomes are estimated, measured, and evaluated, and what is the potential to do that, to look at these holistic processes beyond the therapeutic or treatment intervention effect, measurement, and hence it applies or not? Like, do you think this has a potential to also speak to other ways of doing research, not just in mental health, but more generally?
Oh yeah, that's very broad. You know, the good thing about ketamine is that ketamine has a foot both in the traditional pharmaceutical treatment world and one in the kind of in the psychedelic world. So that's where you start to see a little bit of the crossover and seeing how doing interventions in different ways can impact it. But it's I think a very slow process. Just convincing other researchers who work on ketamine that if they listened to their patients, if they listened really carefully, that there is a better way of optimizing. There's a better way of doing treatments. There's a better way of supporting them through the process. I think that's already a challenge. So I'm not that optimistic that it will change very quickly, but it could.
All right. Thank you so much, Joost. One more round of applause.
Cheers, man.